I'll Thank you. And I'll introduce myself for the three people who don't know me really. My name is Andrea Cortinoa, and I'm an assistant professor cross-appointed between the Dalla School of Public Health and Human Biology in the Faculty of Arts and Science. I work on issues of migration and health and global health. And that's everything you need to know about me, yes. And I would like to introduce Dr. Alexandre Branco-Pereira. Dr. Pereira is an anthropologist from Brazil, and over the last decade, he has been working in the health field, particularly at the intersection of migration and health. And most of his work has been focusing on mental health, analyzing from an epistemological perspective, not epidemiological, epistemological perspective. It's very important to make the distinction.
Yes, very true.
So-called culturally competent mental health services implemented in Brazil, and giving priority to the experience of the racialized population of migrants or immigrants to the country. And more recently has worked to explore the impact of the COVID-19 pandemic on that same population. And Dr. Branco Pereira's work draws attention to what happens in the cracks between disciplines, fields, and categorical assumptions. And his interests include the process of racialization of people on the move, the impact of coloniality and neoliberal capitalism on migration and on the right to health and healthcare of migrants, forms of bottom-up political mobilization of migrants, collectives, and community participation on health policy development, and ontological regimes, production of reality, and epistemological asymmetries, particularly in relation to health. So about 35 minutes.
Okay.
I'll let you know when we get to 30.
All right.
Okay.
So thank you. Good afternoon, everyone. I would like to thank you all for attending to this event. I want to express my gratitude to Dr. Courtinois for graciously hosting my brief stay here at the University of Toronto and for facilitating the collaboration with the Center for Global Health to make this event possible. I would also like to extend my thanks to Dr. Di Ruggiero for your prompt and open support in hosting this lecture. So I'll try to cut some parts of what I was intending to speak. This ethnographic research examines the impact of the COVID-19 pandemic on Black and Indigenous migrant communities in Brazil. By investigating migrants' access to health services during the pandemic, I analyze whether and how the universality of the Brazilian unified healthcare system, or simply SUS, acts as a mechanism of suppression of racial, social, and economic differences. Therefore, my research asks, who is entitled to the universal under this desired model of nationhood? How do the experiences of racialized Latin American and African migrants navigating an universal healthcare system in a self-proclaimed multicultural society inform us about racism, and coloniality? And how do health policies and public policy making respond to racial diversity and complaints of racism by racialized migrants from healthcare systems shaped by narratives of universal access, especially during pandemic times? So I would like to begin this lecture with a quote from Mwewa Lungwe, or Mama Mwewa, a democratic Congolese leader in Brazil. In July and August 2021, amid the ongoing COVID-19 vaccination campaign, the first ever consultation event about health policies designed to engage migrant populations took place in the country. With 5 regional stages, one for each of Brazil macro regions, and 1 national stage, the first national plenary migration and health in times of COVID-19 engaged almost 400 participants from 19 different nationalities. Mwewa was participating in an activity proposed by another DRC leader, Hortense Mbuyi, named La Diaspora Africaine face à la pandémie, the African diaspora during the pandemic. At a certain point, concerns about getting vaccinated against COVID-19 were raised. Participants in the activity claimed that there were 2 different kinds of vaccines in Brazil, one for white people and one which actually protected them against the virus, and one for Black people, which in fact led to fatalities when administered. And at this moment, Mwewa intervened and said, If I'm so scared of getting a fake vaccine, I can get in line and leave a white person in front of me and a white person behind me, so I can get a shot from the same bottle. But if I get sick with COVID, getting the intubation line, honestly, that is a risk. Because you see that there is this case, I'm not just saying it. There was a case in Italy that a boy was sick in bed. He was saying, I'm not breathing, I'm not breathing. And the nurse said to him, you can't get intubated. Why? Because you're black. Because between a black person that is in need of air and a white person that is in need of air, I'm sorry, Alexandre, but we are talking about something that is real. Of course, they will give it to the white person. This is no secret. So I would rather take my vaccine. I can get in line between two white people instead of waiting to get sick. So this quote is significant as it contains multiple semantic layers exemplifying the themes discussed in my work. Firstly, it explores the intersection between coloniality, as in power relations based on racialization processes, and what I term as demi-fake news, how extra-modern populations are exoticized and dehumanized to the extent that the challenging political realities they face are not just considered less important, but dismissed as non-realities. This was evident to the point that Moewa felt compelled to apologize to me, reaffirming the reality of racism. The factual accuracy of the existence of two different types of vaccines is irrelevant because Moewa was diagnosed that public health policies are often hostile to people associated with her social and cultural groups in the Brazilian context. If you do not protect yourself, hostility will manifest in different ways because racism extends beyond the vaccination campaign. The fear Moewa expressed is rooted in the realization that she was hardly safer in Brazil than in Congo or anywhere else globally. This world, shaped by nation states, public health policies, physicians, nurses, and academics, is entrenched in a white supremacist, colonialist, and neoliberal culture. Here, I consider culture as the open, if not cybernetic, system of meanings and context, echoing Gregory Bateson's descriptions, which are not neutral signifiers to a non-responsive world. Malcolm Ferdinand brings our attention to the case of the Zong slave trade ship, originally named Zorg, which ironically means care in Dutch. The ship departed from Accra, Ghana in 1791 with 442 enslaved Africans and arrived in Jamaica with only 208. As it was overcrowded and running out of drinking water, several crew members and enslaved Africans were dying or sick due to the harsh conditions of the journey. Luke Collingwood, the ship's captain, ordered that 132 enslaved Africans be thrown into the sea while still alive, including women and children, just one of the several examples of this horrific practice. During that time, insurance companies did not compensate for enslaved Africans who died due to mistreatment or if they died on shore. However, they did pay for losses resulting from the consequences of a storm or a natural death, such as drowning in the sea. Understanding this, the crew saw heavy rain ahead as an opportunity to maximize profits, ensuring they would receive financial compensation for their lost goods. Shortly after the massacre, the heavy rain actually fell, resolving the drinking water problem. A parallel can be drawn between COVID-19 and the Zong massacre. In both cases, there was a journey into the storm akin to slave trade vessels, where some were on the deck while others were hidden as cargo in the basements, embarked but out of sight. Ferdinand terms these colonial power configurations as the basement politics. Similar to the Zong massacre, the decision to sacrifice some commodities, actual human beings locked in the basements of modernity, was rationalized for profit preservation. And when it comes to COVID-19 pandemic, Moewa and her colleagues knew that not only no one was trying to protect them, but instead they were being targeted. This is one of the reasons why the COVID-19 pandemic should not be viewed as a manifestation of natural forces, but as intrinsically connected to broader political aspects of our time, such as the global rise of the far right, white supremacy, colonialism, neopositivism, and neoliberalism. But let's not put the cart before the horse. Allow me to provide some context regarding the methodology and the theoretical framework of the research before delving further. In terms of methodology, I conducted ethnographic work among various racialized migrants communities across Brazil from 2020 to 2023, encompassing a significant portion of the ongoing pandemic period. Throughout this time, I actively engaged with the political demands of my interlocutors, taking on the role of coordinating networks of migrants, migrant rights advocates, and health professionals. This involvement began locally in São Paulo, which is South America's most populous city, and expanded nationally from 2021 onward. It is crucial to note that I didn't receive any remuneration for this work. As a migrants' rights advocate, I was frequently prompted by my interlocutors to assist in organizing and voicing their political demands. Together, we orchestrated three collaborative initiatives involving civil society organizations and governmental health services to administer vaccines to migrants in marginalized and predominantly non-white neighborhoods in São Paulo. This initiative dismissed the requirement for the presentation of Brazilian documents, which was an illegal prerequisite for accessing the SUS. As a result, over 100 racialized migrants, primarily from Haiti, Venezuela, and Bolivia, were successfully vaccinated. Additionally, I played a role in organizing two national consultation events aimed at compiling the demands of migrants for healthcare from every corner of Brazil. I also accompanied the first migrant delegations to participate in one of the country's national health conferences. These actions engaged more than 2,000 people, and I analyzed over 140 hours of recorded activities. Furthermore, I documented discussions from 263 meetings. That's a lot of meetings.
Pause for effect.
These meetings between March 2020 and November 2023, these meetings were organized by both civil society organizations and local and federal governments, addressing topics such as the public health response to the COVID-19 pandemic, as well as the organizations and strategies for political mobilization and denouncements of violations of access rights to the healthcare system. In addition to migrants, my ethnography led me to engage with three other categories of interlocutors within this context: state agents, health professionals and managers, and public health authorities. I represented the network and the National Front for Migrant Health, which I currently coordinate, in at least 3 government working groups established to design equitable health actions and policies for migrants, a direct outcome of the political mobilizations I previously mentioned. This is significant for 2 reasons. Firstly, despite working as a mediator between organized migrants and state agents, I was often perceived by both as someone aligned with migrants and their demands, even though I was neither. Secondly, I had the opportunity to register the not uncommon clashes between perspectives that only interstitial spaces like these can accommodate. The confrontation of discourses, narratives, and demands is a central focus to my work, as I mentioned earlier, largely inspired by a social psychoanalytic approach inaugurated in Brazil by the renowned Black anthropologist Lélia Gonzalez, but present in decolonial scholarship since at least Frantz Fanon and his work Black Skin, White Masks. These confrontations allowed me to comprehend the gaps between worlds and understand how these gaps are filled by those engaging in this ontological choreography, defining categories, approaches, and priorities. I would like to lay some theoretical grounds over which my work walks. Agreeing with Bruno Latour, I consider that the diacritic sign of modernity is precisely the division between nature and culture, or the Great Divide. We know that the foundations of modernity also encompass models of extraction of resources, labor, and land, a broad dehumanization of non-white and non-European populations treated as commodities, mass and ongoing epistemicide with profound epistemological and ontological asymmetries between moderns and extra-moderns, deemed as the indistinct mass of racialized people outside the core of the West. But it is under the rubric of the distinction between a passive nature available for ownership and manipulation by an exceptional kind of life, or a particular race that does not see itself as a race, that all the other approaches lean on. Passivity and exceptionalism are therefore the dyad in which the binary framework of modernity will operate, and it is through this dyad that the asymmetries of power, whether local, global, or epistemic, will find justification. The establishment of this division brought into the idea of universality. A byproduct of the modern episteme, the idea of universality raised the category of humanity of universal scope, linear and relatively uniform development, and often averse to contextualization. Even though ethnocentrism may be the most universal of human characteristics, as Lévi-Strauss affirmed, the articulation between the notion of humanity and the notion of universality presents itself as a diacritical trait of thought attributed to the macro block that is commonly called Western culture. Modern notions of humanity and universality are associated through the attribution of universally shared basic characteristics that symmetrize everyone individually and collectively, supporting, among other things, the structure of policies guaranteeing not only human rights, but also a say regarding of what realities exist or not. As the critical traditions and perspectivism demonstrate, access to the universal status of humanity that is worthy of rights does not encompass a myriad of subjects and creatures considered infra or non-human. Feminism, feminist, anti-racist, decolonial studies, and perspectivism have demonstrated that the failure to guarantee access to certain life possibilities for certain populations was closely linked to the greater or lesser consideration of the affected communities as equals. The category humanity is not only universal, it is culturally specific, but it is also an index of access to power. Thus, access to the status of universal humanity whose rights are ensured becomes a central political agenda, since the Club of Humanity is not open to everyone, as Ailton Krenak says. Particular universalities are thus created, capable of simultaneously advocating for the inclusion of all subjects and excluding certain groups incapable of fulfilling all the criteria of humanity stipulated by such situated perspective. In the representation of the universal particular dyad in two diametrically opposed and exclusive poles is illusory, in addition to analytically and empirically unproductive, because it's established distinctions between two poles that are often hybrid. Its presence is especially felt in the nebulous zones of epistemological interstice. In the field of health, the dyad is often represented on the one hand by fields of knowledge that deal with structural, material, and objective components of reality, universalizable components immune to contextualization, and on the other by those that deal with symbolic and accessory superstructures whose own universal property is variability, such as cultures, societies, meanings attributed to a structural external world that is unresponsive to this movement. Social scientists and even psychologists and psychiatrists are often faced with the task of having to repeatedly prove the relevance of social, historical, cultural factors in health approaches, and are often instrumentalized as devices to reduce resistance in communities that clinicians, public health professionals, and epidemiologists want to access. If belonging to the humanity club is an indicator of power, it subsequently defines the hierarchization of symbolic thought. As a manifestation of human exceptionalism, often transformed into white exceptionalism or Western exceptionalism, symbolic thought distinguishes humans from non-humans, or those who access and wield power from those who don't. The dissociation of symbolic thought from the passive nature outside of us leads to hallucinations. Worlds that are deemed real, especially because symbols materialize life, as Donna Haraway pointed out, but only for those who experience them, whether individually or collectively. To briefly illustrate my argument, I will present two examples. I would present three, but I think that we won't have time. First, the Nationality in SUS campaign, an initiative from migrant political movements demanding the collection of nationality data for those infected or deceased by SARS-CoV-2. Secondly, the tensions between universality and equity in the Brazilian universal healthcare system. And that's it. The third one, I'm not going to. Okay. So the first ethnographic example is from the campaign called Nationality in SUS. Since the beginning of the pandemic, the network I coordinated highlighted the lack of data on the nationality of those infected and deceased by COVID-19. This mobilization, inspired by similar demands from Black and Indigenous rights movements for identification in health contexts, drew attention to the absence of information on which communities were more affected, in which territories and why. James Lalani, a Haitian public health researcher based in Brazil and member of the network I coordinated, had written a technical note pointing this out in late April 2020, which was sent to Brazil's Ministry of Health, remaining unanswered until the beginning of this lecture. Last time I checked my mail. Subsequently, another letter was produced and sent on May 22, 2020 to the Health Surveillance Department of the Ministry of Health. The letter emphasized that data regarding the nationality of those who had COVID-19 or died as a consequence of its complication could not be entered into the epidemiological surveillance information systems, even if collected, as there was no field to input such information. This letter received a response from the Ministry of Health on June 17, which is displayed. The current SARS form has the patient's residence data in line with all the other individual registration forms of other diseases reported in the country through the Notifiable Diseases Information System. Among the available information, there is the variable country if residing outside Brazil. This field is automatically filled in by the system when the patient is a resident of Brazil. For cases in which the country of residence of the patient is another one, there is a table with the code and name of the countries that must be filled in. That is, the Ministry of Health has stated that the collection of information about the country of origin of individuals with SARS was only conducted when they were associated with migrants residing outside Brazil, overlooking the nationality of those residing within the country. And the final paragraph emphasizes, it is important to highlight that the variable residing outside Brazil does not correspond to collecting information regarding nationality. However, the available variables already include information related to the country of origin and which are important for the epidemiological context of each case, allowing the investigation by local surveillance and in the identification of the profile of the disease in Brazil. By affirming that, the ministry confirmed that only data regarding the nationality of non-residents were of interest as part of its policy for information collection and structuring the epidemiological profile to support the response to the pandemic. In essence, the collection of nationality data would function as a tool for controlling the influx of these people, only concerning those who posed an actual epidemiological threat, meaning those residing outside Brazil. This approach does not view data collection as a means to support equitable responses to the inherent inequalities that immigrants living in Brazil were facing during the pandemic. And without records, these challenges were occurring, yet they were being disregarded as if they never happened, an imposed hallucination. So this is controversial. Hallucinations are defined as the perception of an object or event by any of the five senses in the absence of an external stimulus. The existence of phenomena considered hallucinatory requires an objective and factual reality. Hallucinations do not differ at the sensory level from the experience of reality. We could all be hallucinated random. Additionally, the distinction between internal and external is crucial. As Lerman argued, determining whether the source of an experience is internal of the self or external not of the self is essential for defining what is or what is not a hallucination. If the source of the perception is internal to the minds and brains, that is, not shared and creating an essentially individual world disconnected from what is considered the common world, it is more easily categorized as a hallucinatory phenomenon. However, deciding whether a phenomenon is sensorially activated by an externally considered stimulus is there actually in an objective external space is a task that requires external arbiters to individuals' brains and minds. Such a world does not exist before its construction, as argued by Bruno Latour, since this reality will always be hallucinatory. If there are no substantial differences between hallucinatory perception and real ones, other than the existence of the external stimulus in a concrete and objective space, it is necessary to collectively assess this existence, and reality becomes a collective construction. In this way, power asymmetries play a decisive role in the collective definition of realities, determining which collective worlds are real and which are misinterpretations. Furthermore, this is one of the mechanisms for creating the basements of modernity I mentioned earlier, allocating politically uncomfortable perspectives out of the world. Isabelle Stengert argues that physicists responsible for defining reality as objective and transcendent to human fictions equated attacks on their field of knowledge with attacks on rationality itself. From this perspective, one had to either agree with what they presented as reality or be not only against physicists, but against reason itself. The definition of reality based on the elaboration of an external nature is an everyday political phenomenon, and questioning it produces tensions, expose power asymmetries, including those between different epistemological traditions. This highlights that there are privileged positions for defining what is real or what is not, and consequently, which worlds exist and which worlds does not exist. Our campaign also spurred a lawsuit from the Federal Public Defender's Office in June 2020. The lawsuit demanded the collection of nationality data from both the municipality of São Paulo and the federal government. I will draw attention to two aspects of the response provided the Municipal General Attorney's Office of São Paulo, or MAGO. First, MAGO stated that the inclusion of the nationality marker would only be important in a hypothetical future scenario where the community transmission of SARS-CoV-2 ended, emphasizing that monitoring and controlling the nationality of origin of important cases might be necessary. And this reinforced the notion that during the pandemic, public health in Brazil considered migrants only as potential pathogenic agents. The second aspect I would like to highlight is the assertion that the care provided for migrants will not change even in the face of nationality data, considering what Mago pointed out as the legal precepts of SUS. The response from Mago explicitly states that even if the requested data were available, the development of actions for migrant populations would remain unchanged. The legal principles of the SUS presuppose universality of access, guaranteeing healthcare to all individuals seeking primary or emergency care assistance without any form of discrimination, including without documents. It also emphasizes comprehensiveness, promoting a coordinated and continuous set of preventive and curative actions and services, both individual and collective, tailored to each case. Additionally, equity is stressed, emphasizing that the need to consider health system users in their differences and inequalities to ensure equal access and utilization of the healthcare system, even among those who are unequal. Thus, under the pretext of ensuring equal treatment for all accessing SUS, the argument is made that there should not be different health promotion strategies or policies responsive to the various contexts in which SUS operates. Collecting information on the nationalities of those infected and deceased by the disease would be considered innocuous because from that data, no specific healthcare policy for migrant populations can be derived without potentially violating the universality paradigm of the system. In this perspective, treating everyone the same way, regardless of their differences and inequalities, is advocated to maintain universality, actually. The second example is regarding the vaccination actions. In Brazil, 2021 began with the promise of an inclusive, comprehensive vaccination campaign. On January 17th, Monica Calazans, a Black nurse who worked at the Emílio Ribas Hospital, was immunized in the presence of the governor of São Paulo a few minutes after the approval of the emergency use of vaccines by the Brazilian Health Surveillance Agency. The choice of a Black woman was made to symbolize the inclusive nature of the upcoming vaccination campaign. Monica was a resident of Itaquera, which is a low-income easternmost district of São Paulo, and had worked as a nurse at 2 jobs since 1985. What followed did not maintain continuity with the action in January. In February, research already indicated that the adoption of age criteria to define priority groups for vaccination, to the detriment of adopting territorial and consequently racial criteria in the city of São Paulo, meant privileging less vulnerable groups in terms of access to immunizations, directing vaccines to territories where there was no evidence of excess mortality and that had a greater concentration of white and high-income populations. Between May and July, research demonstrated that the Black populations in the peripheries of São Paulo were simultaneously those who died the most and were vaccinated more slowly, even when considering groups eligible for vaccination at the time. So on the left, you can see a map with the territorial distribution of Black and brown population in São Paulo. And on the right, the immunization rates divided by district, the territorial distribution of immunization rates. So you can see the neighborhoods, the districts that has more Black population were the ones in which the vaccination was more slow. I'm gonna be quick. Since the onset of the campaign, the presentation of certain documents, such as the Brazilian SIN number and proof of residence, have been mandatory for vaccination in São Paulo and in most of the country. Even though it was waived by several laws and other normative instruments. Partnering with the Association of Immigrant Women Light in Life, a collective that represented over 400 migrant women that lived in marginal neighborhoods in São Paulo, a series of 3 vaccination events were organized. The main demand posed by us to the health teams engaged in the action was the dismissal of presentation of any Brazilian documents as stated in the law. On the map, you can see the 3 districts in which the actions took place. The first one was in Lajeado, 200 people attended, 38 first doses were administered, corresponding to 19% of the total population present that day. The second event took place in Cidade Tiradentes. 29 first and 6 second doses were administered among a total of 180 visits, which corresponds to 19.4% of the vaccinated. And by that time, approximately 83% of those who were vaccinated at this joint action were initiating their primary vaccination cycle, which took place more than 2 months after the São Paulo City Council's announcement that the entire vaccinable population at the time was already immunized with at least 1 dose. And the third joint action took place in Guaianazes and was attended by 112 migrants. This time, 24 people, were vaccinated with their first dose, 8 with the second dose, and 1 with the third dose, the booster dose, representing 29.5% of the public present at the joint action. And once again, the majority of those vaccinated at this joint action were administered their first dose and were therefore completely unprotected until the last 2 months of 2021. In total, 106 people were vaccinated, corresponding to 21.5% of the total number of immigrants attended. Of these people, 91 or 18.5% of the people attended, and almost 86% of the vaccinated public had not taken any dose of the vaccine until they were immunized in the joint actions. That simultaneously demonstrated that there was a large proportion of racialized migrants not immunized yet, and that the equity actions that we were demanding, such as the dismissal of the presentation of documents, were effective as a strategy to amplify access of rights to SUS. And these are some pictures of the events. So I have one more. I'll finish the last ethnographic example. Throughout the pandemic, as I said, I was involved in organized 2 national consultation events aimed at gathering contributions from migrants all over Brazil regarding health actions and policies they considered priorities for the healthcare system. The first one was the first National Plenary on Migration and Health, which I already mentioned. And the second one was the first National Free Conference of Health of Migrants held last year that had an attendance from 876 people and was the first of its kind in Brazil's history. For those unfamiliar with the Brazilian community participation system in designing health policies, I encourage you to look it up. Additionally, for the first time, a migrant delegation was sent to the National Health Conference, responsible for deliberating on the health policy to be implemented in the country. These events collectively approved a total of 4 directives and 24 proposals that were subsequently included in Brazil's National Council of Health resolutions number 715 and 719 as priorities for the 2023-2027 Health Actions Plan, a groundbreaking development in Brazil. Following this, the Ministry of Health established a working group to design the country's national health policy for migrants, refugees, and stateless people, and we successfully managed to include migrants in it as a direct result of the mobilizations I have mentioned before. I think that this is it. There was just a few more things, but I think that we have, it would be better if we could discuss a little bit the questions and insights. So thank you again for this space, and I'm happy to hear your insightful comments and questions.
Thank you. Well, I definitely have questions, but I would prefer to let others start. I think it was a very rich presentation. You focus on, obviously, on the reality of Brazil, but there are so many things that you mentioned that are really relevant for North America and other areas of the world. And I was thinking about the example you gave at the beginning, for example, of the child who could not be intubated because it was Black, right? And the I can't breathe symbol of fundamental symbol really of racism in North America. Similarly, the idea of migrants as pathogenic agents is fundamentally the history of North America and still very powerful. I'm thinking about the Ebola epidemic in Africa and the reaction that we had in North America to that. I closed the airport. It's still very, very powerful.